This is the extended version of the Buyer Beware Problems with All-on-4 lecture. All-on-4 is also known as a hybrid, a fixed implant denture, an implant denture, or more specifically or more accurately, a fixed detachable implant prosthesis. This slide shows on the upper a traditional all-on-4. The lower image is that of an implant bridge. And I'll ask you right from the beginning, which one looks more human? Which one looks more natural to you viewers? So where did all-on-4 begin? It actually began in Portugal over 10 years ago. Originally, it was a treatment designed to treat patients who were already missing their teeth. And over the past 10 years, it's morphed into treating patients with some or all of their teeth. I'd like to say from the beginning that I do like hybrid treatments for the lower arch. It is more cost effective, and I do them willingly. They do not adversely affect the speech. The contours can be convex and easily cleaned, and these are the factors that make a lower hybrid much more ideal than an upper hybrid. You can see here a patient with a lower hybrid. We don't have to compress the tissues with a prosthesis. We can make it easily cleansed. The contours can be proper, and I believe a lower hybrid or an all-on-4 restoration is a fairly nice restoration. It's not the best restoration, but it is a nice restoration. The U.S. corporate dental implant practice model began about 10 years ago. I'd like to ask all the listeners and the viewers from the beginning, does it make sense that one treatment technique could be right for all patients? And I would refer you to many other industries. The automobile industry is a great example. Does every car fit the needs of every consumer? If we go to orthopedic surgery, there are many, many different types of joint replacement implants. There's no one implant and there's no one technique that is right for every patient or every joint. So it stands to reason that one dental treatment cannot fit the needs of all patients. I'd like to state what we learn in dental school, and our oath binds us to do no harm, to preserve healthy tissue, and to provide treatment options. So think about those three issues as we go through this lecture. Why is it so popular? First of all, it's very lucrative. It's very profitable for those places performing all-on-4 treatments. It's become globally. It's almost a global pandemic. It's so popular. And private practitioners feel compelled to recommend it simply to be competitive in the market. All-on-4 has gained immense and overwhelming popularity through television ads, radio ads, billboards. The market has been saturated with advertising for all-on-4. So many consumers are convinced that it is the end-all be-all treatment in implant dentistry. But here are the list of compromises that I want to present and discuss today. First of all, the traditional all-on-4 protocol requires massive bone reduction. The protocol also involves placing angled implants, which require angled abutments. These angled abutments cause soft tissue issues. They also prevent proper cleaning. There are speech issues that are involved in the upper arch. Early on in implant reconstructions with titanium and acrylic restorations, as well as some of our zirconium restorations, we had multiple incidences of tooth breakage and denture base breakage. Overall, the All-on-4 technique and resulting prosthesis caused a very, very high incidence of tooth and denture breakage. This continues today. So first, let's talk about bone reduction. All-on-4, the traditional All-on-4 protocol, requires extreme bone reduction. And by extreme, I mean 11 to 15 millimeters of bone removal in each arch, which is a ½ inch. So if you're doing both arches, you're talking about 22 to 30 millimeters of bone removal, which is close to one, well, actually it's in and around 1 inch, depending on how much the surgeon removes. I think this slide will put it into a better perspective. If you imagine a ½ inch being removed from both jaws, resulting in 1 full inch of bone removal, it's pretty staggering. Hold your finger up and picture 1 inch of bone removal. It doesn't even seem like it should be part of any human treatment protocol. Here's a corporate slide that I've seen a dozen times in lectures over the years when they present All-on-4 treatment. I want you to note that this bone is a healthy, precious commodity. It can be used in your implant reconstruction, but it's removed with a surgical reciprocating saw to make the treatment easier for the doctors. And I found this picture through some friends who saw it on Instagram, where a dentist who does a lot of All-on-4 treatment took a surgical reciprocating saw and cut the jaws out of this patient, put them on a patient napkin, and then had a very braggadocious comment below the image. So what's the problem with that bone removal? Cortical bone is that hard outer layer of bone on all of our skeletal bones. And the problem is that once that cortical bone is gone, it's gone forever. It cannot grow back. So that hard, dense surface of bone, once it's removed and we get into this softer underlying bone called the trabecular or the cancellous bone, it's much softer and much more susceptible to ongoing resorption and changes. The second big compromise for All-on-4 is the angled implants and the angled abutments. In order to make the surgery fast, the protocol is to place these angled abutments like you see in these two radiographs. Bone doesn't like these abrupt contours, and these angled abutments have caused significant bone and gum recession over the years for many of these patients that I see on second opinion appointments. So the interfaces that we have in our body naturally are all smooth and gentle transitions between bone, ligaments, tendons. Everything in our skeleton has smooth, gentle contours, and that there's a reason for that. The angled implants have now sharp, abrupt transitions, and soft tissues do not like that. From day one, there's inflammation around these implants, and it never goes away because of the irritation, but also the subsequent prosthesis causes the tissues to remain inflamed, causing ongoing problems. But this starts on day one. The third compromise is soft tissue issues. Because of the contours and the angled abutments, the soft tissues can really never be cleaned properly. Before we go into those explanations about soft tissue problems, I would just like to say not all patients are good candidates for same-day teeth. All of us in reconstructive implant dentistry can do same-day teeth. We have to be able to do that for patients who qualify, but it's not appropriate for everyone. So when you see the advertisements about same-day teeth, many of them make it sound like that office or that corporation only does same-day teeth. The reality is that many of us do it, but the judicious use of same-day teeth is for those patients who actually qualify. The key about immediate or same-day teeth is the tissue. Keratinized tissue is the key to success. Keratinized tissue is the light pink tissue around the teeth, and if you think about your palate, the roof of your mouth, that is all keratinized tissue. It's firm, hard tissue that resists the forces of chewing. Here's a slide that shows you what that gingiva or that keratinized tissue looks like. In patients with thick, healthy, robust keratinized tissue, we can do same-day teeth successfully. If there is thin or missing keratinized tissue, before the implants are done, it will only get worse over time. And with the worsening comes bone loss and gum recession. This really never stops once it begins. A patient with very thin and missing keratinized tissue, you can actually see through these tissues. The white areas just below my arrows are actually bone, so you're seeing through the tissue and visualizing the bone through the thin tissue. This is a patient who is not a good candidate for same-day teeth. And if you do same-day teeth in a patient, here's the result. 6 months after implant placement and immediate teeth, you now have the implants exposed on the patient's left, and you have all 4 abutments exposed. So tissue is the key. And here are other patients who have come to me after All-on-4 treatment with implants and abutments exposed. I think you can all imagine how much plaque and tartar you can see here, but also how difficult these are to clean. Yet another patient. These are actually implants and abutments both exposed because there wasn't adequate keratinized tissue to start with. And yet another patient with the same problem. As you can see here in the lower, this area right here is not just receded gums, but it's also infected. This soft tissue presentation is called hyperplasia, and with ongoing irritants of plaque and tartar, it gets worse and the tissues start to get angry. Now you can see a little bit of pus in this picture, and this is the beginning of the slow loss of this implant. And when I read many articles in our journals, they downplay the problem with this. And again, because it's a worldwide or globally popular treatment, there's not a lot of honesty even in our publications. You can see here they downplay it here, localized peri-implant soft tissue recession around a few multi-unit abutments. In my experience, it's far more than a few. The fourth compromise on our list is cleansability. Angled implants and angled abutments prevent the patient from thoroughly cleaning under the prosthesis. This leads to bone loss and tissue recession as well as bad breath. But the other part is, in order to have proper speech in the upper jaw, or speech is largely dependent on our tongue meeting the backs of our upper front teeth. If we don't have a good air seal between the prosthesis and the gums, the patient tends to lisp when they speak. That's unacceptable to 100% of the patients. So in order to correct that, we must place pressure on the tissue with the prosthesis. And that design is what makes these upper all-on-4 prostheses nearly impossible to clean. You can see here's a nice picture of some of the plaque and food material that gets around the implant and the abutment. And here's an example of a patient who saw me on a preoperative visit. She went somewhere else to have her implants placed because she got a better deal. So she doesn't have great keratinized tissue. As you can see here, it's thin. All the way around it's thin. It's unhealthy. And there's not much volume of that good keratinized tissue, but there actually is some keratinized tissue. So had the implants been placed properly, she could have probably had a much better outcome. She returns to me a year later with this temporary in place. And what you can see here are the implants and the abutments. The implants were placed far too forward and at much too steep of an angle, so they had to be corrected with angled abutments. So now she can't speak properly. She's lisping because air is flowing over the top of this prosthesis. It's very hard to close this down without causing food entrapment, but no patient will accept lisping while speaking. So we have to choose the lesser of two evils. So we create an uncleansable situation and have to pick that over speech over cleansability. So how we do that is we create this large zirconium bumper that covers the implants and the abutments. So now her speech is corrected, but we've created an uncleansable situation. And why is it uncleansable? Let's talk about that. Here it is in her mouth, and I think you can picture between the image of the temporaries that were wide open and the image of the final restoration here in zirconium, that whole area is covered and can't be reached by brushing, flossing, or even with a water pick. And here's why. These concavities that you see right here, spanning the entire prosthesis, some worse than others, create an uncleansable contour. So concavities are nearly, if not completely, impossible to clean. And here you can see, using superfloss, which is one of the techniques for cleaning these restorations, here's a large void that cannot be flossed because the floss gets stuck here and here on the edges of the prosthesis and cannot be contoured to fit into the concavity. Even a bigger void here on the front of the prosthesis that can't be cleaned because the floss touches here and here, but can't be contoured to fit into the concavity. So what we try to do, and this is a pretty simple solution if you can get the laboratory to understand it, is we try to create convexities rather than concavities. Convexities, then, with floss, you can imagine that floss can go pass underneath the prosthesis and completely touch all parts of the area that is convex. So this is a simple laboratory solution to the cleansability problem. It's rare that the labs understand this and do this because the dentists don't understand it and do it. So just to review, the intaglio surface is the tissue surface of the prosthesis. Concave is bad, convex is good. Here I'll show a real-life demonstration of the problems that a concave tissue surface creates. What you see in this picture is a lower hybrid prosthesis that is concave all the way around the arch. I apologize for the gross nature of this picture, but this is what happens when prostheses are designed in a concave manner at the tissue interface. Food, plaque, and tartar begin to accumulate within days of the delivery of this prosthesis. The solution is where acrylic resin can be added to all the concavities to create a round form, and then what I did was take the edge of the acrylic on the outside, the edge of the acrylic on the inside, rounded and polished the surface, so now the patient has a chance for flossing, brushing, and even water picking to clear out the bottom of the prosthesis of food, which leads to plaque accumulation. So even when we don't have implants and angled abutments exposed, or I should say there hasn't been gum recession around these abutments or implants, by the nature of the prosthesis, with the saddle form of the prosthesis, the uncleansable form of the prosthesis, he's developed a yeast infection. So he doesn't actually have any failing implants or abutments, but he's got a failing prosthesis because the contours are uncleansable. This is a yeast infection. I'd like to discuss this x-ray for just a minute, and I'd like the viewers to take an overall look at this x-ray and tell me if it looks like a reasonable outcome. Does it look like a human mouth? It appears somewhat alien to me, but I'll allow you to draw your own conclusions. Another point I'd like to make about this picture is a newer design in implant dentistry where the implant and the abutment have a different diameter. This is called a platform switch, and technically it's called a horizontal offset, and it means where the implant diameter is slightly larger than the abutment diameter. And the theory behind this is that this offset allows the soft tissues to heal into this recessed area and form a tighter soft tissue seal between the implant and the abutment. In theory, I believe in it to some degree, and when the implant and the abutment connection are below the gum tissues is when it works appropriately. The problem, like I've shown you in earlier pictures, is that angled abutments cause bone loss and gum recession. When that occurs, this platform switch or this offset becomes exposed to the oral cavity, and it traps food and bacteria, leading to plaque and tartar, and sadly, ongoing bone loss and ongoing gum recession because of the ongoing irritation. So here's a crude drawing just to give you some idea of why these areas are so difficult to clean. This is the implant here. This is the angled abutment here. So what it does is it takes this screw and it changes the angle to here. So this would probably be a 17-degree angled abutment. That's not my point of this slide. The point is that if you look at the areas that have to be cleaned, in a well-placed implant, without any bone or tissue loss, you have these areas that are called, one is a sulcus and multiple are sulci. It's the gap in the tissue between the pink and the tooth, or in this case the abutment, that we have in our mouth naturally. And this is a cleansable situation because this area can be accessed by floss. Not completely accessed, but for the most part, this is a cleansable situation. The problem is when we have a little bit of bone loss and a little bit of tissue loss like you see here, it changes the position of the connection of the abutment. So now, instead of having a small sulcus, you've got a very large one, in some cases measuring between 4 and 8 millimeters. And there's no way that patients can get floss in those areas. Cleansability is virtually impossible. But especially in 3 dimensions, when you consider that this entire area is covered by titanium, plastic, or zirconium, depending on the type of restoration that the patient has. So even if we could get into one side or the other, we can't clean circumferentially around this cylinder because it's blocking our access for floss or even water pick or even brushes. There's no way to get to that area once you've had the bone loss and the gum recession. Here's a picture of the implant bridges. And from this picture, I hope you can appreciate the fact that even though these teeth are sitting on implants, they look like natural teeth. And that means that they can be cleaned just like natural teeth through brushing and flossing as normal. And this is what an X-ray of implant bridges look like. All the implants are straight, like the roots of teeth. All the abutments are straight. So the contours are gentle and flowing, and each area between every tooth is accessible with floss. So if I show you the actual prosthesis that was made in the lab, what I'm trying to point out between these 2 images is that this area is just like it is in your dentition, in your natural teeth. All these areas are perfectly cleansable with floss. So without angled implants and abutments, with proper contours, the patient has at least a chance to be able to clean between the prosthesis and the gums and around each implant connection. So with implant bridges, I'll contrast these drawings, and what I'm going to show you here is that around an implant bridge, you have a normal sulcus, a normal depth of soft tissue around the prosthesis that measures anywhere between 2 and 4 millimeters. And that's perfectly accessible to the patient in all 3 dimensions with dental floss. So we don't have this cylinder that blocks our access to the sulcus. The cylinder is actually the same size as the restoration that gives circumferential access to the cleaning of the implant underneath. So the 5th compromise are speech issues. We talked about this in an earlier section, but in the upper jaw, the prosthesis must put pressure on the tissues to prevent lisping. The design, and what I mean by design is the pressure plus the concave form creates the uncleansable situation. And I showed you this case earlier where this is cleansable because it's accessible, but the patient's speech is highly compromised. So we have to cover all that up, which restores the speech, but now makes it uncleansable. So what can be done if you have existing All-on-4 and you have speech issues? We can add to the prosthesis where it meets the gums, and that does help with the air seal. Many times we can modify the existing prosthesis. No matter what material has been used, we can modify the prosthesis to accomplish this goal. Like I showed earlier, we can turn concave into convex. Tissues have elasticity, so when you add this convexity to the prosthesis, it puts a little bit more pressure on the tissue, but almost all tissues can accept this. From day one, the All-on-4 industry has been plagued by tooth breakage and denture base breakage problems. Tooth breakage problems, especially in the upper jaw, were a common problem with All-on-4 treatment. The denture bases often broke away from the titanium skeleton also. The reason was that the materials are not very strong in thinner sections, and this problem is what led to the aggressive bone reduction that is done now with All-on-4 protocol. If you've removed more bone, you can make thicker titanium and thicker plastic sections, which are stronger. But again, the bone loss will never recover. You'll never get that bone back. And perhaps the biggest compromise in upper jaw All-on-4 treatment is the ethics involved. I don't list this as part of the mechanical problems with All-on-4 because I believe it deserves its own category. Here you see a patient of mine from a number of years ago. She had great teeth and great bone for the most part. She had some compromises. She was missing one upper and one lower tooth, and she had one broken upper tooth. All in all, she's got 25 healthy teeth. They're not very pretty, and that's what she objects to. She did not have the financial resources to do anything complex, so we came up with an intermediate option that would buy her some time. We made her these beautiful temporary crowns that restored her smile and her confidence. So the plan was that she was going to use these for a number of years while saving money to come back and do a better option, which involves saving these healthy natural teeth. So sometime a few years after we gave her these temporaries, she was searching online for options. And she came across a corporate implant center where the website convinced her that All-on-4 type treatment was the best way to go. She went for a consultation, and the salesperson convinced her that her teeth really weren't that good, that she didn't need to save them, and that this All-on-4 style treatment would be her permanent solution for the rest of her life. So in one fateful day, she went from all those teeth to these 9 implants. And I can tell you that as you're listening to this presentation, that if it's a weekday, in the United States, there are dozens of people losing their healthy natural teeth because they've been convinced that All-on-4 implant treatment is superior. And it is not. Think about the worldwide situation. Today alone, hundreds of people around the world are losing their natural teeth to make way for this type of implant treatment. So she swallows her pride, she contacts the office, and she comes in crying about her outcome. You can see here that she's got implants and abutments exposed. She's got these huge upper and lower titanium and acrylic prostheses. Her speech is not the same. She realizes that she can't clean underneath them, and she's heartbroken. And unfortunately, I tell her that the only thing I can do for her at this point is make her smaller, prettier prostheses. I can't reverse anything that was done to her at the other office, surgically. On my website, I talk about the differences between All-on-4 and what I call the Fast and Forever Smile. which are implant bridges. And you can certainly pause here if you'd like to review these comparisons. So what are the alternatives to All-on-4 treatment? The very best option for full arch replacement of teeth with implants are implant bridges. These resultant teeth look, feel, and function just like natural teeth. Here's a patient that comes in with just a few remaining teeth, and as you can see, they are failing profoundly. We treatment plan her for implant bridges to replace both upper and lower arches in the most natural fashion. That same patient's panoramic x-ray shows her failing teeth, but also shows good bone support. There's a slight infection right here that we'll manage at the time of surgery. But more noteworthy is notice how much bone she has below her sinuses in the back of her upper jaw on both sides, and even has bone in the back of her lower jaw on both sides. So rather than removing that bone to make room for a thick prosthesis, like is done in the All-on-4 protocol, I save this bone. This is a precious commodity that can be used for implant placement that enhances the strength and the aesthetics of the final prostheses. Here's her panoramic x-ray on the day of surgery. We removed her remaining natural teeth, we removed 0 bone, and we placed 12 implants. Notice how they're all parallel. They will not require angled abutments. Her immediate fixed teeth that same day. Here are her final zirconium prostheses. There's 8 implants, but there's 4 pieces. And the beauty of this is that occasionally we have implant failure. It's only 1% of the time, but if this patient's one of the unlucky ones that has 1 implant fail, the biggest problem we have is this 5-unit section right here. But we also have, it could also only be a 1-unit section like this one. And the difference between this treatment with implant bridges and All-on-4 is that if you lose 1 implant with All-on-4, the entire arch fails. The entire prosthesis becomes obsolete. These implant bridges are screw retained. It's a very hygienic connection between the bridge and the implant, unlike the old method where we used cement that could become a contaminant. And this is what her mouth looks like on the day of delivery, the day we give them the new restoration. We fill those holes in with a composite resin so that you can't feel it with your tongue and so that food doesn't pack into those screw holes. And here she is 2 weeks later. Her teeth look, feel, and function just like natural teeth. The implanted teeth are just like her natural teeth. Without seeing this x-ray, any observer would be hard-pressed to realize that these teeth have implants underneath them because they look so natural. Notice how parallel all the implants are, just like the roots of teeth. Tell me if you think this looks more human. And her smile is completely restored. She's from there to there. And compare upper to lower. Let common sense rule. And again, they're cleansable. The key here is that these teeth look, feel, and function like natural teeth, but maybe the most important attribute is they're cleansable just like natural teeth. Okay, the other alternative are implant overdentures. And these are not the best possible solution to tooth loss. But what they do is they're much less. These are dentures that snap onto implant. So we take patients who have failing dentition. We place similar number of implants. Make these connections. These are called abutments. These are the attachments that go inside the denture. The rigid connection between the abutment and the attachment is what allows the denture to snap into place. It's held stable for chewing by this connection. The other advantage is that the patient can remove the denture and it can be cleaned outside the mouth, while the abutments can be easily cleaned inside the mouth. It provides these advantages. First, the cost is much lower, approximately half that of the All-on-4. It gives the patient the opportunity to save money over a few years, at which time they can come back and convert their treatment into the fixed restorations. So what if you already have All-on-4? Unfortunately, because most of the useful bone was removed, there are very limited surgical options for revision or correction. In rare situations, we can remove implants and they can be replaced for an improved outcome. Almost always this involves bone grafting in addition to implant removal, because again, all that healthy bone was removed to make way for the All-on-4 prosthesis. So what happens if you have breakage or food entrapment? The most effective way we have now to solve breakage problems is by converting titanium acrylic prostheses to zirconium prostheses. This is a fairly expensive solution, and it doesn't fix the soft tissue problems, but it usually resolves the breakage issues. I'll close with a few examples of these treatments that I think are so phenomenal for my patients. This patient lost his teeth due to cavities. On the upper picture you can see where he came in. On the lower picture is how we finished. The upper arch is implant bridges, look, feel, and function like natural teeth. In cases like you see here, sometimes patients wait too long. Mother Nature removes the bone prior to them seeking treatment. And on occasion we have to use pink porcelain. But the difference here is that all the implants are straight, there are no angled abutments, and it is still cleansable because the tissue profile is convex. And the third patient had lost her teeth over many years and waited 30 years to get dental treatment. And in spite of that, she still had enough bone to do this type of treatment with straight implants, no angled abutments, and easily cleansed contours. So thank you for watching, and feel free to click through the rest of the website for other examples.